Good morning, Dean. I'll ask you to present yourself for the first prostate cancer and prostate disease podcast. So please introduce yourself.
It's great to join you. I'm Dean Elterman. I'm a functional urologist and associate professor at the University of Toronto here in Toronto, Canada.
So let's go to it's very, I think it's very interesting especially for urologists that do this every day. So you actually went through three new minimally invasive techniques through your manuscript. It's a very practical manuscript, I think. It's very good for all the urologists that are starting these new exciting minimally invasive options for BPH. So I will start for aquablation. So I think that one of the most important questions for urologists is what it's, in your opinion, the ideal patient.
Well, aquablation is a really unique surgical approach. Perhaps all three of these are unique, but what aquablation does is it really gets the best aspects of a more traditional surgery, which is resective, ablative, removing tissue, but with an emphasis on maintaining some of those quality of life parameters, such as erectile function and ejaculatory function, and of course, continence. So unlike other minimally invasive procedures where there are some limitations in prostate size, anatomy, volume, aquablation is almost agnostic to size, meaning the ideal patient is pretty much anyone. The water study showed that it was superior to TURP in prostates 50 grams and above. So you could argue for prostates that are 50 and above, you could prefer aquablation. But really, the ideal patient is any prostate that comes into the office, any size. They can have a median lobe. It can be over 100. It can even be over 150 milliliters in size. And it's for someone who wants a resective technology, an ablative technology, but also someone who wants to try to preserve sexual function.
And to better understand how you manage patients, so do you do it under general, regional anesthesia? Do you stop anticoagulants, antiaggregants? And what do you do at the end of the procedure? Do you put a normal catheter? Do you put some irrigation, just to understand what a beginner, let's say, would have to expect from such a technology?
Yeah, so I think aquablation gets lumped into minimally invasive therapies. And I mean, we lumped it in this paper, of course. But aquablation is really an operating room-based surgery. And, it requires either a general anesthetic or a spinal anesthetic, unlike office-based MIST. So this is not an office-based MIST. This is a surgical procedure. At the end of the case, and the cases typically take less than an hour to perform, so they're relatively quick regardless of the size of the prostate, we will put in a catheter, typically a 22 French three-way catheter. We will run bladder irrigation. Many of these cases are now being performed as same-day cases, meaning they go home the same day. But for most of the world, patients are staying at least one night in the hospital. Catheter duration is typically just that one night. Maybe they'll keep it in for 1 to 2 days. And then that's the main aspects of post-operative care.
Okay, and what are the complications you're afraid the most normally? Or what worries you before the procedure, or something you should be aware before starting such a technology?
Well, I think one of the benefits of aquablation is that because you're doing real-time imaging and planning of the prostate in terms of where the ablation or resection is going to be, it actually minimizes a lot of risks. So we know exactly where the verumontanum, we know exactly where the external sphincter is. So rates of incontinence are exceptionally low, less than 1%. With respect to ejaculatory function, because you can contour around the apex of the prostate in the viru, rates of ejaculatory dysfunction have been reported around 10%. And in fact, the more contemporary series, I think it's less. Postoperative hemostasis was something which historically was a concern. In the large Water 2 study, they didn't do any hemostatic maneuvers at the end of the case, and bleeding was higher. But they've now gone around to having a much better technique called focal bladder neck cautery. And as a result of that, the rates of bleeding have gone down to exceptionally low levels. So in a series of several thousand patients, the rate of transfusion is 0.8%. Last year at the AUA, I presented the most recent contemporary series of 10,000 patients, and the rate of bleeding is less than 0.2%. And so I really think that the days of the concern around bleeding or aquablation are generally historical. And with a modern approach using focal bladder neck cautery, the rate of bleeding is in the 0 point percentages, which is very low compared to other technologies.
Well, I think that's what we get from also the techniques. I mean, zero is not, it's for any technique. I mean, I think it's really difficult to go for bleeding to 0%, especially because when you have complex patients, it becomes more and more difficult. So let's go for Resume. What is now your ideal patient? How do you think? What's the patient you have in your mind for Resume?
So Resume is really, now we're switching over to an office-based minimally invasive therapy, or MIST. Resume, as you know, uses water vapor, steam, injected into the prostate. And the ideal patient is really, at least based upon the clinical trials, prostates between 30 to 80 grams, with men who wish to preserve sexual function, including ejaculation. And it does not matter whether they have a median lobe, right? Median lobes are okay with Resume.
Okay.
What we've found over the last several years, in fact, and it's been reported in the literature, is that the size of the prostate can actually go larger. So we've reported in prostates bigger than 100, bigger than 150, and the results seem to be very similar, if not equivalent, to prostates between 30 to 80. And so the ideal patient is really a prostate between 25, 30 grams, all the way up to, you could argue 100 or 150 for perhaps, in those men who wish to preserve sexual function.
And here, what do you do with antiaggregants, anticoagulants? Do you need, you said it's an office-based, but do you still do it in the operating room, or just it can be proposed as an outpatient? How do you, what's the ideal setting for this kind of patients?
So these cases can definitely be done in what many in North America would call an office-based setting. Essentially, you need a bed with stirrups and some way to administer any number of different types of anesthesia.
Right.
Because BPH, BPO surgery is generally a quality of life surgery.
Mm-hmm.
For all of these, I typically recommend holding blood thinners because, again, you want to minimize your risks. However, I think Resume has been done and can be done with blood thinners continued. You just have to exercise some caution and let your patients know that there's a slight risk. Mm-hmm. But yeah, these office-based procedures are done much more quickly, and we give less anesthesia. So you can give just a local block. You can give oral sedation. You do a prostate block, conscious sedation, but it does not require full operating room, doesn't require full general anesthesia. And you put in just a 16 French catheter at the end.
Okay, so you don't need irrigation in these cases.
No, that's correct.
Because there's some debate on how long to keep the catheter in. What do you do in the everyday? Because that's a big question actually.
Yeah, so in the clinical trial where prostates were around 45 grams, they left catheters in for 72 hours, and the rate of retention was around 6%. That's our baseline working. Many people have advocated a 10 cc per day rule, so 30 cc's 3 days, 50 cc's 5 days. In my practice, I've tried just to standardize it. Prostates around 80 or less, we'll leave in for a week. Bigger than 100, we leave in for 2 weeks, 10 to 14 days. Of course, you can make adjustments. If you do a small treatment, 2 days is sufficient. We really try to do less treatments because it will have less adverse events, urgency, retention, etc. But the magic number is still to be determined. But it does need a catheter, for sure, a few days longer than other non-heat-based technologies.
And what do you do? What do you give them in the post-op? Do you give them something to alleviate? Because that's one of the main concerns. Let's say if for people who don't do them, aquablation maybe they're concerned of bleeding. here they're concerned about postoperative symptoms, or how are your patients? Do you, let's say, do you receive many phone calls from patients saying that they want their catheter out, or are they? Because some of the authors says that it depends a lot on the number of injections, because when you see it live, actually you don't a difference from other ablative techniques. Here you don't have the result in front of you. I mean, you have to wait for your results. So maybe that's the other. You will agree with me that the number of injections is probably still the other big debate on this technique.
Yeah, you know, so I think that the catheter duration still needs to be a little bit clarified. We've done some recent research showing that the number of injections, first of all, does not correlate to the volume reduction, meaning if you give more injections, you think you'll have a better result. The answer is no. And in fact, we've even have some really recent data showing that perhaps even the number of injections doesn't really matter. It could be more so patients who start with a very high IPSS, patients who have a high PVR, and patients who have or develop a urinary tract infection. Those are actually three risks for prolonged retention. So that needs to be looked into a little bit more carefully. But I would say that the catheter for Rezum has not been a major issue, at least in my practice. Patients have not declined it, getting Rezum for the catheter. And I think the catheter is just, once they expect it, it's really not such a major issue that I've found, at least.
Okay, perfect. I think that we can go for the last technique. So TPLA, I think that here the patient is completely different. So I would like to know who do you reserve this technique for?
So TPLA, or transperineal laser prostate ablation, is certainly one of the newer techniques available. It is ultrasound guided in order to see the prostate, and you put in a series of Chiba needles through the perineum into the prostate. And once you have the correct location with software guidance, you put in a diode laser, which creates a thermal necrosis and a lesion within the prostate. The literature really shows that this is very good at preserving ejaculatory function. And so, my take on this is for men who want an office-based mist, who want ablation, right? But really prioritize sexual function, particularly ejaculatory function, TPLA may be appropriate. And in the literature, again, the prostate sizes are anywhere from 25, 30 on the low end, reported up to about 80 on the high end.
And what do you think? Because I think that many authors would place this technique for very high risk patients, because here I believe, and so I asked you that probably have more experience, if you really do not stop any medication with these patients, because it's very minimal the damage we do to the patient. So many authors say that they just keep everything in, so very high risk patients, and so probably very high risk anesthesiological patients, maybe best patients for this.
Yes, I mean, TPLA certainly requires a very small amount of anesthesia requirement, right? It could be done with just local anesthesia. You just do a little numbing of the skin. You can do a prostate block. The patient can be awake. And so, I don't like putting certain technologies with high-risk patients, because then it gets pushed just to that side. But it is certainly an advantage in that it requires such little anesthesia that you could do high-risk anesthetic patients, those on blood thinners, those who can't get a more heavy type of anesthesia, because it is really just putting in a needle into the prostate, that's all.
Okay, and here, do you really need, you don't need to have the patient in, right? You can do it as an outpatient, like you do transperineal biopsies, I suppose.
That's correct. So this is entirely, at least what we would describe as an office-based procedure. The patients can go home the same day. The only thing I would say is the treatment times are a little bit longer compared to, say, Rezum or Urolift. They've been reported anywhere from about 25, 30 minutes up to 60 minutes, let's say. So you need to have a little bit more time in your procedure room to have the ultrasound guidance, put the needles appropriately. The actual laser treatment itself, the diode laser, takes probably about 20, 25 minutes of lasering time. So it does take a little bit of time, but the benefit, of course, the patient goes home same day.
Okay. And here you put a catheter in, right?
I think most people would say put in a catheter because, again, you're just coming into the transition zone on either side of the urethra, sparing the urethra, but a little bit of edema could occur. And so a catheter is put in, but it's only a day or two at most, I think would be reasonable.
Okay, so I think that to make a final statement over the three different techniques, I will use one of your tables. I think this is a table that can easily help us to understand the best, a bit of a summary of what we've been saying now. So what I would like, something you said really, I think it's very interesting. So you believe that there is not a technique for each patient. That's something good, because I think that most authors or most surgeons would be maybe not very convinced of using TPLA, probably because it's the one with less evidence in the literature. I mean, probably aquablation with the water trials have given urologists the good evidence-based information to go through with aquablation. So, and what I would ask you is, how do you think these techniques will evolve in the future? Do you think that some of the techniques will have more or less space, or will it depend on different countries? Because one of the main issues, especially in Europe, is the reimbursement, because the reimbursement of these procedures are very difficult. I mean, most of them have a base of cost that is high, especially for the device that you're using. And most of the devices are, at least for Resume and for TPLA, they're single use. So this may create some difficulties.
Well, I think, a general takeaway is that historically, men really didn't have a choice. We had resective technologies that were considered more invasive, required hospitalization, and had an exceptionally high, if not guaranteed, loss of sexual function, ejaculatory dysfunction, affecting erections. And as a category, the idea of bringing in MISTs, minimally invasive therapies, to balance symptom improvement with preservation of quality of life, sexual function, is really important. We know from patient studies that it's important to them. And many men are quite willing to trade off slightly the long-term durability of resection with the benefits of preserving sexual function. Of course, cost will always be an issue everywhere in the world. But I think the idea generally of being able to have these technologies as an option is really important. Clearly, every urologist isn't going to be able to or need to offer every technology. Those of us who specialize in BPH will, but I like the idea that at least there's going to be options for men. And of course, these technologies will evolve in time. There will be next generation technologies for all of these coming out, which will have added benefits, greater accuracy, greater efficiency, greater outcomes. So we need to keep our eye on this space. I think it will evolve. It's not going away. And certainly, aquablation is a surgical procedure, but again, it has that nice balance. Resume seems to be doing very well around the world in terms of a minimally invasive ablative procedure. Both of these are in international guidelines because they have a high level of evidence. They've had lots of publications. And TPLA is newer, so they don't have as much publication, but it is certainly from the literature out of Italy and other countries growing in the experience, and we'll have to keep an eye on it as well.
Okay, so what I would like to know, two more important things, is that you decided to focus on ablative techniques. So now the question is, what do you think ablative techniques, or why they should be preferred over the other mists that are non-ablative, so they're more compressive or more, or they have other kind of mechanisms?
So there are non-ablative, minimally invasive techniques. These are typically device-based techniques that use implants, whether they're permanent implants or temporary implants. And they definitely show symptom improvement, right? We've seen clearly IPSS symptom improvement, quality of life symptom improvement. So the non-ablative, minimally invasive techniques may be very good for well-selected patients, particularly those who want to preserve sexual function. The only question is, at least in my mind, around durability and whether there is an advantage of having an ablative technique because you are removing tissue, which, if left, could eventually become obstructive again. We all know that prostates will regrow, right? We all know that all treatments have a retreatment rate, regardless of what you do. And so the minimally invasive therapy space is, you could divide between ablative and non-ablative. They're all good. They're all in well-selected patients appropriate, but there may be differences in the long term with respect to durability. And so I think that might be a differentiator.
And what another important question, you know that there is not a lot of urodynamic data on this kind of procedures, so probably we really don't know how much patients are really deobstructive from one side. And from the other side, you know, especially from legal point of view, these are ejaculation sparing techniques for most of them. And so what do you say to your, because actually, well, for TPLA, probably you'll go for 100% ejaculation sparing technique, but for I know that for aquablation and brace room, you may not be able to give 100% to the patient. So how do you manage this? Because that's the same problem, you know, like a classic technique, like just an incision of the prostate has a very high ejaculatory preservation rates. But you have always this problem that, especially for young patients, that you may not be able to guarantee the 100%, or do you feel that confident to give 100%? So that's an interesting topic that I would like to go through with you.
So when it comes to urodynamic disobstruction of bladder outlet obstruction, I would certainly say that aquablation, there's no doubt that it disobstructs because it's being compared to TURP and it removes a lot of tissue. And so clearly you're disobstructing even on urodynamics with aquablation. There have been studies. There's an Italian group with Cindolo who reported changes in urodynamics with disobstruction from Rezum. And so I think that Rezum can be disobstructive. When it comes to ejaculation dysfunction, I think that we have to look to the literature and give our patients an honest assessment. When it comes to aquablation and Rezum, they are ablative technologies which are considered ejaculation sparing, but in the literature, the rates of ejaculatory dysfunction are in the single digits, which is great, but they do have to be told to patients ahead of time for counseling, right, for informed consent. So I tell my patients that their chance of ejaculatory dysfunction is probably less than 10% for both of these technologies, which is much less than a resective surgical type of outcome. So when patients are weighing POLEP or TURP or green light versus one of these mists, their chances are much lower with them, but it is not zero. And that's why you have perhaps still the options of the non-ablative techniques. But yes, we always have to look at the literature and report the numbers for our patients so that they understand, because the number is not always zero. It's true.
So, and what do you think that the literature should focus in the near future on? So do you think that they should, because most of these techniques or some authors would like to compare them to classic techniques with randomized trials, but I believe it is not probably the best setting, because I don't know if we really believe, or we probably already know they're not as good as prostatectomy or as a classic TURP, besides maybe for aquablation, which is really a classic, let's say, resection technique. So different from the other ablative technique that use different kind of energies. So what do you believe the literature should focus on, especially to give the right place to these techniques and to make life of urologists easier when explaining? Because now a patient maybe has to have a degree in BPH before choosing, right? He had like
Right.
50 of options, and so it's difficult for the patient. Very often he goes like for marketing things, he likes more water or more laser, so it depends a lot. And so sometimes it's difficult for the clinician to clearly understand what's the best for his patient, because probably patients cannot really decide from themselves, right?
Yeah. So I think that there's going to be two different ways for us to evaluate these minimally invasive treatments.
Mm-hmm.
Because I agree with you that comparing them to TURP is a good historical comparison, but it doesn't necessarily tell the whole story. So one would be a composite measure evaluation. So similar to the BPH6 where they did UroLift versus TURP. If you can look at other types of metrics that are important to patients, including sexual function preservation, duration of hospitalization, return to work, all these other sort of what we call softer measures, you'll find, as they did in that UroLift study, that in fact the composite score favors the non-invasive or less invasive mists. So I think composite scores may be a good way of looking at it. And the other is to really not necessarily compare it to TURP, but maybe compare it to either other minimally invasive therapies or probably more appropriately medical therapy. The vast majority of men are on dual medical therapy. Yeah. We know historically what dual medical therapy does. And because these are less invasive and many men are choosing minimally invasive treatments to get off of medication, right, as an alternative to medication, perhaps another way of looking at it would be compared to medical therapy. And there are a number of studies ongoing comparing mists to combination medical therapy, alpha blocker 5-ARI. And I think that that's a very reasonable comparison.
And what do you think it's, because you brought up a very hot argument in BPH, meaning that actually outcomes are not really standardized. So when you go for the BPH6, that's probably one of the most standardized sort of evaluation of patients. Then from the other side, because it's a benign disease, we are moving towards a more patient perspective, but patient is subjective. So it's a little bit difficult. I suppose that when you went through the literature in this review, it's actually difficult to compare different techniques, because most of the times it's not an absolute. I mean, there's no big difference in 8 or 10 or 12 in Qmax improvement, or 6, 9. So what do you think we should focus on to understand better, to compare better patients? Because, if you put in the same bowl patients who are sexually inactive, all patients, they all have different expectations from surgery. So I would like to know your opinion on what's the best outcome, or should we go all with BPH6? What's your opinion on this gap in the literature about standardization in outcomes?
I don't know if we'll ever be able to get away from our classical ways of evaluating IPSS, peak flow, PVR. I mean, those are the language that we all speak. Mm-hmm. But with new categories and new types of treatments, they don't tell the whole story, right? Mm-hmm. And something like the BPH6, which you could use as a standardized measure, at least takes into consideration other important factors. And when we talk to patients, they actually don't care about their peak flow, right? This is not something that they can even understand or I mean, they understand, but it's not important to them. What patients want to know is, do I feel better? Yeah. How was my recovery? Have I been able to preserve function? Was I able to get back to work? Was I able to avoid pain and complications? And so we need to have measures that capture outcomes that are important to us as urologists, but also translate into something meaningful to patients so that they can be involved in the decision as to what to choose.
Yeah, I believe, I strongly believe that with the new mathematical models that we'll have with AI and this all new way of interpreting what actually our patients say, we will probably improve this, because probably we'll have complex scores that will be not only mathematical, they will be more comprehensive. And so probably we'll try to understand better which patients feel better with our techniques, and probably also have an idea if that patient is ideal for that technique. So I think that we will end up this very interesting first podcast. I'm really happy that we did it. This is a big step for the journal, and so I'm happy that you wake up this early, so directly from Toronto. So I really thank you for your time. It's valuable for us, and I think that we will succeed in this path to promote prostate cancer health and BPH health. So thank you. I don't know if you want to say something to close the program.
Well, thanks for this excellent discussion. And it's a pleasure to join for this inaugural podcast. And congratulations to PCAN, Prostate Cancer Prostatic Disease Journal, to Cosimo and everyone on the editorial board for this new initiative, and wish you all the best in your subsequent podcasts. Thanks for having me.
Good. Well, have a good day, and thank you a lot. Okay. Bye-bye, Dean. It was a pleasure.
Thank you.
Bye-bye.
Thanks. Bye.